My name is Sarah Bateau, and I'm the Deputy Institute Director of Nuclear Medical Applications at SCKCN, Belgian Nuclear Research Center. And I'm delighted to be your host today, alongside with my co-moderator, Victoria Wostak-Stack, and for this event. And I'm also grateful to the support of Filippo Gander, Francisco Cortes Ortega, Kirsten Löfgen, and Thomas Kokolios. So we've organized altogether a webinar that we believe will capture your interest. And we have three distinguished speakers that we will hear in a moment. Asta Juseniene, Koen Vermeulen, and Clarita Sadalriaga. So please be aware that this seminar will be recorded today and will be made available on the PRISMAP website. So thank you for joining us. So today, these presentations will be given in honor of the World Cancer Day and also aligned with the 2024 thematic Close the Care Gap, which so celebrates the cancer progress in its many forms. And so PRISMAP is really pleased to present and to organize this distinctive webinar. And we will focus during this webinar on showcasing the most recent breakthroughs in both preclinical and clinical cancer research within the PRISMAP consortium. Regarding the cancer problematic, every year we know that around 2.7 million people living in the European Union are diagnosed with cancer, with 1.3 million people still dying from this disease. So, and we know that it's much too much. And thanks to the progress, on early detection and diagnosis, on effective therapies, on supportive care, the cancer survival rate has continuously increased in Europe and in Belgium. But the number of cancer survivors, even if it's esteemed to 12 million people in Europe, including around 300,000 childhood cancer survivors, still we can rejoice, but there's still work to do. So we should not ignore that cancer continues to rise, and we need to join forces from the academia, from the clinics, from the industry, and from research consortia like the PRISMAP consortium to continue to improve cancer treatment, survival, and the quality of life of patients. Regarding the PRISMAP project, it's really a pioneering project that serves as a European medical radionuclide program. Very important also because it helps for nuclear therapy, molecular imaging, are both really part of these promising medical procedures in hospitals, and they have the potential to significantly enhance outcomes for various medical conditions. PRISMAP benefits also from a big and a large consortium, which is a network of esteemed partners and institutions across Europe, and I would like to thank them also for being here today. And its primary objective is to support ongoing research both in Europe and beyond, facilitating the immediate access to a range of novel radionuclides. So having said all that, I would like to to welcome you again and to ask Victoria to introduce herself, as well as to introduce our first esteemed speaker.
Hello, I'm Victoria Wojtacka. I'm a PhD student at KU Leuven studying radioactive ion beam production, and my work focuses on terbium nuclides. And it is my pleasure to introduce our first speaker, Asta Juseniene, who is an associate professor at the Department of Physics at the University of Oslo and the group leader at the Department of Radiation Biology at Oslo University Hospital. Her team activities are fully devoted to development and preclinical testing of novel radiopharmaceuticals for cancer therapy. And Asta, the floor is yours.
Thank you very much. Do you hear me?
Yes, we can hear you.
Okay, thank you very much. Today I would like to talk about what we're doing in our lab. And as it was mentioned, that metastatic cancer and cancer is the main reason for cancer death. And if totally around 10 million people dying from cancer every year, 7 million are related to metastatic cancer. And for these patients, as you see in the screen, prostate, breast, ovarian, stomach, lung, colon, it's not so many months to survive. And this metastasis must be treated. They cannot be treated by external therapy because this is in different organs. They are metastatic. And radiation therapy, radiotheranostics, is very promising method not only to diagnose and to find these cancer cells, but also to kill these cancer cells by using targeted radionuclides. I cannot move to the next slide, sorry. Yes, and our aim in PRISMAP project is to do testing of novel therapeutic radionuclides at clinically relevant activities in vitro. And today I'm going to talk about this targeted radiopharmaceuticals, because you know what, we have two types of targeted radiopharmaceuticals, that it's naturally accumulating in the cancer organs, in cancer cells, like Sofigo that is developed in Norway and accumulates in bones, or targeted using radionuclide linker with chelator and targeting moiety. And this two, Pluvicto and Lutathera, based on lutetium, were recently approved for neuroendocrine and prostate cancer cells expressing somatostatin or prostate-specific membrane antigen. But each cancer requires specific radiopharmaceutical, and to find this target, it's the main issue that are not overexpressed in normal tissues. And in this lecture today, we are talking about targeting moiety, not about antibodies that circulates in blood for 2-6 days, not until antibody fragments, but we are talking mostly about small molecules that circulate in blood from few minutes up to few hours. And why we have chosen to study lead, actinium, and lutetium? Because we have lead generator in our lab. We can do experiments daily. Actinium-225 is very difficult to obtain, but we can get it through PRISMAP project. Thank you very much. And lutetium-177. And if we want to compare, the main to compare alpha versus alpha, alpha versus beta, I don't talk about the distance. I just mostly interested in alphas because we can kill hypoxic cells, we can kill radio-resistant cells. We have not require many alphas to hit DNA, only 1 and 5. And according to theory, alphas are more suitable for small lesions of few micrometers, while lutetium can treat bigger lesions due to the range in the tissue. And why do we need to have actinium or lead PSMA therapy when lutetium PSMA is already approved? Because not all patients respond to lutetium PSMA immediately, or they become non-responsive with time. And this is very classical example from Kratochvil, what patients stop to follow to lutetium PSMA therapy, but after 2 sessions with actinium PSMA, that black lesions disappeared. What is wrong with actinium PSMA today? It's only limited supply, and I think PRISMAP can fix this problem. Additionally, it can be toxicities related to the instability if it will occur due to the daughters. And how do we do our research? First, we make radar labeling, check radar chemical purity, binding. Then we test this radar conjugate in vitro radar toxicity in 2D cells and 3D. We think about and measure DNA damage, and then we do in vivo studies. I go very fast. However, we have one of challenge when we do in vitro experiment. Actinium, lutetium, lead, they have very different half-life. And how long do we need to incubate cells with this radioligands? For 1 hour or for 2 hours? However, decay and absorbed doses will be very different.
Other screen.
And other thing, when we do, we have, remember first, we add radioligand to the solution. Radioligand binds to cells and we have internalization. We also need to think about, as I mentioned it before, clinical relevance. What in blood, it's not functioning very long, less than 1 hour. This is big challenge if we want to compare, because we don't have this situation if we do X-ray, because this is 4-5 minutes, and when we can start to analyze cells, we deliver all those at the same time. And we also need to think about importance of cancer cells. Today I'm talking about prostate cancer cells, and we have 2 different cell lines. And as you see, PEEP cell line has around 10-20 times higher expression of prostate-specific membrane antigen in vitro and in vivo than CF42 cells. Do we have much better results in vitro and in vivo if we use this PEEP cell line in comparison with CF42 cell line? And if we do quality control of lead radioligand targeting PSMA, we see what this PEEP cells has around 60% of totally added activity bound to the cells, and of that 10% internalized, while CF42 it's only 20%, however it's internalized 50%. And what we do after we do, as I mentioned, in vitro testing using clonogenic assay, flow cytometry, and we also make spheroids, as we call 3D model. Even we do standard, golden standard clonogenic assay, we incubate with lead for 1 hour. However, in different conditions, in the first case, cells adherent, in the cells second time in suspension, we get different activities, little dose 50 to obtain. And here I also added blue line. This is the line not having PSMA expression. And in order to reach that, we need to have above 150 kilobecquerel per milliliter. And as you see, between adherent cell and suspension and between these cell lines, we have differences, what we always need to take into consideration. And as I mentioned it very fast, way to see what is happening with cells to perform flow cytometry. This is PSMA cell line PEEP, very positive and weak PSMA expressing, and to see immediately huge differences. And if you see, we have decrease in S phase, increase in G2 phase, and it lasts from day 1, day 3, day 6. We don't have so much changes in this cell line. And of course, in CF42, we have less expression and changes are not so dramatic at the same activities. If we look for viability, we don't observe any apoptosis or necrosis after day 1. It starts from day 3 and day 6. You have increase in PEEP line and CF42, very similar results. This is, as I mentioned, for lead. If I go for DNA damage, it's very fast way also to test double-strand breaks and to see the time cost, what we have increased DNA damage with activities and with incubation time. Now the first comparison, because as I told you, we are not getting actinium so often, and if we look for the cell cycle analysis, we see very similar tendency, however, at different, of course, activities. And we would like to make a microdosimetry study and to go from kilobecquerels per milliliter to grays in order to calculate and to compare this saline. As I also mentioned in the group, we are using spheroids, and we start with very small and we start to grow. Blue line, it's non-blocked, this line, and blocked means what we add cold targeting moiety PSMA, and even for 48 hours, and after we add for 10 minutes, and after we add radioligand. And if you see, if we keep even for 48 hours, we don't observe any toxicity, only non-blocked activities that can kill the cells. We did similar experiments using lead, lutetium, and actinium-225. We found activities for each of them which stops growth of spheroids. And in the future, we think to calculate absorbed doses and RBA. And it's also very important to calculate number of cancer cells and to see what is happening with time. As you see, this is for 1 week and this is for 2 weeks, but after some activity, the cell starts to regrow. As I mentioned, it has very high expression and CO2 low. But if we compare data in vivo, we don't see so big differences in biodistribution. And if you pay attention, in tumor, we have around 20%. In this cell line, it's also exactly similar data. Other important parameters like tumor vasculature plays an important role. And if we go to mice, survival, time of days, PIP cell line, CO2 cell line, control treated line, with the same radioligand, we see very similar therapeutic outcome. Therapeutic index, when we mean survival 50% of treated group, we divide from control group. And PSMA expression at biopsy is not relevant measure of response to the PSMA. We would like also to make relative biological effectiveness in the future by treating the same model of mice with the same tumors with lutetium, PSMA, and actinium in order to calculate absorbed doses and RBA. In summary, we need to think when we do experiments about importance of cancer cell line viability assays, and maybe to use, instead of expensive methods, very simple flow cytometry that allows to measure N viability, DNA damage, cell cycle, number of viable cells. In the future, of course, it would be interesting to look for the new targeting, new target and targeting moiety. Thank you very much for listening me. Sorry what I was not very clear because I little bit have cold, and thanks to my group.
Thank you so much, Asta, for the very interesting presentation. Now, does anyone have any questions? We have a few minutes for questions.
So if there is no question directly, maybe we can move for the sake of time to the next speaker. Thank you very much. It was a very clear presentation. And maybe we can also pick up some questions, some general questions for the three speakers at the end of these three presentations. But let's move to the next speaker, Koen Vermeulen. Dr. Koen Vermeulen is a scientist working in the radiopharma research group at SCKCEN. And he's part of the team which focuses on the development of new radiopharmaceuticals and preclinical evaluation in different cancer models. And he will focus in his presentation on exploring the potential of high molar activity samarium-153 for targeted radionuclide therapy with samarium dotatate. So Koen, the floor is yours. Thank you very much.
Yep. Thank you very much, Sarah, for a nice introduction. So in this talk, I will be, like Sarah said, going over use of samarium-153 the first time as a targeted radionuclide therapy radionuclide. So let's see if my screen is moving. Yes, samarium-153, what is it? It has a half-life of 2 days roughly, and it decays from primarily via beta minus particle decay. Also interesting, it has some gamma components, which makes it usable for SPECT imaging, and it decays to stable europium-153. Here I give a small comparison between lutetium-177 and samarium. So on average, the amount of energy per particle is higher for samarium, and also interesting, the amount of Auger electrons and internal conversion electron yield is higher for samarium. If we compare this for terbium-161, this is around 12. So terbium is still the leader in this, but samarium is a nice second in this respect. Samarium-153 is generated by bombarding of samarium-152, a stable one with neutrons. We do it here at the PR2 reactor. But the downside of this, that you create a sample that contains both components, and in this respect, this will yield a low specific activity or low molar activity. Nevertheless, it can still be used for bone pain management, and this is currently also on the market. Thing is, with this lexidronam, this has also been labeled with lutetium-177, and the effects are quite similar, so that's a good thing to know. But in general, what to remember from this slide is that samarium, this kind of samarium-153 is not usable for target radionuclide therapy because of the low specific activity. Now, what did some colleagues do of mine recently? Michiel van der Voorde, Maarten Ooms, and André Burgoyne. They tried to have a collaboration with the Medicis at CERN and also some partners, internal partners of BR2, to generate high specific activity samarium. So what they do is irradiate the samarium-152 at BR2. The mixture will be sent to Switzerland, Medicis, where it will be put on the mass separator, and then it will come back to SEK, where it will be purified. And this yielded an increase of specific activity up to 260, 265 times. So that's quite an improvement. Downside about this is that we send around a couple of gigabags, but because of the transport and the purification and mass separation, etc., and the general half-life of samarium-153, we only get some megabags, bags, or roughly 100 to 200 megabags, but this is enough for preclinical investigations. So that's exactly what we try to do. We'll try to, for the first time, use the samarium-153, high specific activity, for a target radionuclide therapy. And for this, we need a carrier, and we didn't look too far. We chose dotatate for this. I don't think I need to explain what dotatate does or what it is. Targets SSTR2, neuroendocrine tumors, and it's also Lutathera, the lutetium version, is also FDA and EMA approved. But in this study, it was more of a proof of concept study that we can use samarium-153 labeled to dotatate as a target radionuclide agent. So that's exactly what we did. First, starting with the radio labeling, very similar to what has been done with lutetium-177 or terbium-161, sodium acetate buffer, heating it for 15 minutes at 95 degrees, gives us a radiochemical yield of more than 98%, and that's a little bit of the downside because of the amount of samarium-153 we have. The molar activity is not that terrific. It's also not bad, so it's definitely workable. Stability test in PBS human serum and the radial labeling buffers showed that this complex was quite stable up till 7 days. So that's already good news when doing further experiments. Next question was to see if these this samarium dotatate binds specifically to neuroendocrine SSTR2 overexpressing cell line, and indeed it does. Here you can see the data for the membrane-bound fraction. Internalized fraction, we incubated the cells with roughly 2.5 nanomolars of samarium dotatate. And we could reduce it with an excess of dotatate, 4,000 times excess, up to 92% specific binding was observed, and 80% was internalized, which of course explained by the agonistic nature of dotatate. Next thing we did was a general biodistribution in the same cell line. We made some xenografts. Roughly 1 million cells were injected on the right flank, subcutaneous model. And 2 weeks later already we could inject these animals with samarium dotatate. Here I show you the biodistribution data as percent of injected activity, because this has all the organs and excreted mass there as well. So it's clear to see that rapid excretion from the body and high accumulation in the tumor. So after 4 hours, 6% is associated with the tumor, and relatively limited accumulation in the rest of the organs, which is of course good when you're working with targeted radionuclide therapies. So that's already a good thing. It's also what we expected compared to the lutetium version, but these things need to be tested when you're coupling new radionuclides, of course. So there's high tumor accumulation compared to the other healthy organs. And this we also compared in non-tumor bearing animals. So here I depicted data, or we depicted the data as a standardized uptake value. So the injected dose in an organ corrects for the injected dose and the body weight of the animal. It's clear to see that some kidney clearance and also some uptake in the spleen, which is according to expression of the SSTR2 receptor in the spleen as well. Interesting thing is what we see if we compare these data with a tumor-bearing animal. The kidney clearance remains quite the same. There is high uptake in the tumor, but the spleen is almost completely reduced to nothing. And there is a small increase in pancreas, which I cannot really explain. The decrease in spleen can maybe be explained by what's also reported in the literature, is that there is a kind of sink effect from the tumor, because it has such an abundance of SSTR2 receptors that it really captures all the radioactivity from the blood, explaining the reduction in the spleen. Interesting as well, if you look at the tumor to kidney ratios, we do see an increasing trend towards the 3 days time point, so which is also very good that the radioactivity is still associated with the tumor. Next thing we did was try to do some SPECT imaging, if samarium is ideally used for this as well. And as you can see, it is feasible to do samarium SPECT scanning as well. We did a scan on an animal 4 hours post-injection and also 24 hours post-injection. Initially, it's clear to see that there's rapid excretion in the, via the kidneys to the bladder. Tumor is visible. Also take a note of the scale. After 24 hours, the retention in the tumor is quite high, and the liver and the kidneys are quite reduced. So again, this confirms what we see in the biodistribution. Lastly, what we did, we had a look at some in vitro therapeutic potential by doing an MTS and a CFU. For those that do not know, MTS checks the metabolic activity of cells. So if this is decreased, this is also a surrogate for cell viability. And the CFU is a colony forming unit assay where we check the potency of proliferation after treatment. So what we also did was incubated cells with, of course, with dotatate samarium, but also with DTPA. And DTPA is known to not bind these cell lines, so it is retained in the medium, let's say, as a free fraction. and so it acts as a surrogate for effects coming from the medium. These cells were exposed to different concentrations of both radiopharmaceuticals, and it is clear to see that there's a trend in the activity concentration. Higher activity concentration means less viability, but this is very much true for DTPA as well. If we look at the CFU results, it shows a quite similar trend, and this just shows as well that it's always important to take a surrogate for medium as well. This is not really, this is more like an artifact of the assay itself, because we're working with quite high energy beta minus particles that of course can travel a couple of millimeters and hit the cells, even if they're not bound specifically to the cells themselves. One thing we can do to ameliorate this is use higher molar activity of our dotatate, or have a look in the lower ranges of activity concentrations. And then I hypothesize that we do the effect of dotatate should exceed that of DTPA, but still remains to be tested. Then we're already at the conclusions. So what we see that our proof of concept is successful. We can use high specific activity samarium in targeted radionuclide therapy. It shows promising pharmacokinetic profiles similar to what we observed for lutetium and terbium-161. Specific binding, high accumulation in tumor, and a great tumor to kidney ratios. Potential to use for microspect as well. We see a decrease in cell viability. However, there's also definitely a medium effect. And one thing that's definitely needed to get this into clinic is streamline the production of samarium. If we can reduce the time spent of the transport and the purification and the separation, we can get a couple of gigabecquerels, which should be feasible to work with in the clinic. Up to my last slide, of course, I'm just a messenger of this research. This could not be done without the help of my dear colleagues of the NMA Institute, also the people from BR2 and the people from Medicis and KU Leuven. So that was the end of my talk. Thank you very much for your attention. If there are any questions, I'm happy to reply. Thank you very much.
Thank you very much, Koen. A very interesting presentation, and I think there might be some questions. Yes, please, Uli.
Yes, so thanks for the nice talk. At the 24-hour SPECT image, you showed that it doesn't really go to the kidneys, but there was still some diffuse whatever in the intestine or somewhere. Yeah. Did you identify where it goes? And if you would repeat the experiment with lutetium, would it look the same?
I guess it would look the same with lutetium. Well, we didn't really test that myself. I need to dive into literature, but I guess it's quite similar. But the remaining, what you see here is, I guess it's a little bit of the liver and part of the kidneys and the bladder. But compared to like tumor uptake, this is low uptake compared to what is initially observed. This is I don't know, some remaining. Maybe there is some specific binding in liver as well that we can still see after 24 hours. But I don't know. No, for lutetium, I need to check it.
Yeah. I have a question related to the possible limitations of due to the molar activities that you are using of samarium, and could you comment on the type of efforts and possibilities of production in Europe and also globally?
Well, this is not my expertise per se, but what I hear is that what can happen, can help, is if you have this mass separation facility closer to where the samarium is produced. That will help a lot, because transport is from Belgium to Switzerland. Takes 1 day. That's already a lot. So, but I guess in streamlining these separations, making it more efficient. Or even starting with even more. Maybe if you can get like, I don't know if that's feasible, but terabecquerels in plasma giga instead of gigabecquerels, that will also help. But I don't know if there's people up there on the audience, but I guess efforts are being made to, get this into play as well.
And you think for large cohorts of patients, that's that would be kind of possible to organize that?
Well, I guess so. Well, let's say if you look at the lutetium and the lutetium examples, there they inject people with 7.4 gigabecquerels. That's already quite a lot. I don't know if 7.4 gigabecquerels necessary for samarium. I think there's a lot of space there for dosimetry as well, to have a look at this if that's needed. But like I said, if you start with a little bit more, then you end up with more as well. So in large cohorts, yeah, that is maybe future music still, but yeah, difficult to say actually. Sorry.
Sarah, maybe just to give you an update, there is a project undergoing under the PRISMAP to try to increase the yields, but that would be for one patient. And basically there's two ways where they're optimizing. Is one on, us producing more, delivering more to them, but it will not be feasible unless also on the ionization stage, they can drastically increase their yields. And they've been working hard and it seems to go quite well. But so far, the scale we're looking at is trying to produce for one patient already. And now we'll see how far that goes.
Okay, thank you very much, Martin.
Thanks, Maarten.
Okay.
May I please comment?
Yes, please.
So there is a new project currently ongoing that is involving, in fact, SCK, CHUV, Medicis, and the University Hospital of Heidelberg to translate this high molar activity samarium-152 produced at SCK and afterwards mass separated at CERN at Medicis into clinics. And at the end of last year, so we have received a batch from SCK of samarium-153 to be mass separated, and we reach a very nice efficiency. We could ship 1.2 gigabecquerel of activity to the University Hospital of Heidelberg, and that was provided to kick off the clinical trial at Heidelberg with this samarium-153. So our capacity, I know that we shipped in the past around 100 to 200 megabecquerel, as Con said in his nice presentation, but now it's more ranging from several hundred of megabecquerel, so more 500 megabecquerel to more than a gigabecquerel. That's what we did last year. And regarding the activities that we lost in the transport, that's true. So we lose some activity from Switzerland to Belgium, but also in the opposite direction from Belgium to Switzerland when receiving the source. But we made a significant effort on that with our transporter, and now our transporter is waiting at our door, and it's leaving the site 1 hour after the extraction of our sample. So we did a significant improvement on that side to do our best to reduce as much as possible the activities that we lose during the transportation.
Okay, wonderful. Thank you very much, Charlotte. Are there any comments or any questions in the audience for Koen? So if not, thank you again, Koen, and
My pleasure.
I'll give you the floor, Victoria.
Thank you.
Hi, so our next speaker is Clarita Saldariaga Vargas, who is a research scientist in the Department of Radiation Protection Dosimetry of the Belgian Nuclear Research Center at SCKCN in Mol, Belgium. She has experience in Monte Carlo modeling for medical dosimetry applications, preclinical studies with radiopharmaceuticals, and nuclear medicine, radionuclide metrology, among others. Currently, her research is focused on the development of dosimetry methods to support the development of radiopharmaceutical therapy and the effective preclinical testing of novel radioligands. And today, she will talk about computational models of mouse kidney tissues to investigate the influence of absorbed dose heterogeneity in nephrotoxicity in radiopharmaceutical therapy. Over to you.
Thank you, Victoria, for the introduction. Can you hear me?
Yes, we can hear you.
Okay, good. Yeah, so thanks for the introduction and in general to the organizers and to the PRISMAP project for the opportunity to present today. So in this presentation, I would like to show you some of the work that I have done in collaboration with some colleagues to develop realistic dosimetry models of mouse kidneys to investigate nephrotoxicity in radiopharmaceutical therapy. Now, the amount of absorbed dose in tissue is the main factor driving the biological response of radiopharmaceutical therapy. Therefore, the absorbed dose is used to analyze response, with the main goal being the establishment of dose-effect relationships. Then once these relationships are established, together with patient dosimetry, they can be used to predict the response of the therapy in patients, and based on this, optimize the treatment. In radiopharmaceutical therapy, the absorbed dose depends on how much radiopharmaceutical is injected to the patient, then where the radiopharmaceutical goes and how long it stays there, and then also on the radiopharmaceutical properties. The distribution is related to the radiopharmaceutical properties and the patient-specific pharmacokinetics. And then also on the radionuclide decay properties. Radionuclides emitting Auger and alpha particles will deposit their energy very close to the point of emission, so within 100 micrometers, while emitters of beta particles would spread their energy within several millimeters, depending on their kinetic energy. Now, radiopharmaceuticals are often clear to the kidneys, so this causes a prolonged irradiation of renal tissues, which can lead to dose-limiting toxicity. Now, the distribution of radiopharmaceutical is often not uniform in kidney tissues. For example, relatively small radioligands can be reabsorbed in the sorry, I'm having some issues with the presentation. Yeah, sorry. For instance, relatively small radioligands can be reabsorbed in the proximal tubules of the nephrons, and then this can cause a non-uniform dose distribution, which can influence how the kidney responds to therapy, and can also complicate the analysis of nephrotoxicity and also the establishment of dose-effect relationships. And a good example of this is peptide receptor radionuclide therapy with yttrium DOTATOC and lutetium dotatate. So these two radiopeptides show different dose-effect relationships when analyzed in terms of the mean dose to the whole kidney, then indicating that the mean dose is not necessarily a good predictor of the toxicity of just any radiopharmaceutical. Then why is this? The hypothesis that this is related to the more localized dose distribution resulting from the less penetrating beta particles emitted by lutetium, which can result in a less cross-irradiation of the glomerulus, eventually leading to less toxicity. However, the influence of the dose distribution on nephrotoxicity remains an open question, which motivates preclinical studies on this issue. However, the investigation of this issue is currently precluded by the limited accuracy of the dose estimates used to correlate with toxicity. And this is because current preclinical dosimetry is typically done at the organ level, so without considering the potential non-uniform distribution that can result from a non-uniform distribution of the pharmaceutical, combined with a short penetration of alphas and beta particles. Now, preclinical radiopharmaceutical studies, including dosimetry, are useful and even mandatory in the context of radiopharmaceutical development. During the in vivo evaluation, studies are performed typically on mice and rats to assess the radioligand distribution over time, as well as endpoints of toxicity and efficacy as a function of absorbed dose. Here, those estimates at the relevant scale are key to be able to identify the tissue structures that drive toxicity and support a better understanding and prediction of organ toxicity in humans. Now, this is quite important, as eventually these tests aim to guide the selection of the radioligand with the highest clinical translation potential, and also to support the design of clinical trials by informing the prediction of the biodistribution in humans, and also by providing insight on the potentially safe absorbed dose that can be given to the organs at risk. Therefore, in the next slides, I will show you some research that I did during my PhD to develop a realistic multi-region model of mouse kidney for radiopharmaceutical dosimetry, which accounts for heterogeneity at regional tissue level. Now, very briefly, the model was developed based on high-resolution MRI data acquired on a kidney section, on a kidney dissected from a healthy mouse. The different tissue regions were segmented on the MRI image and then were validated against histological data of the same kidney. And then this model was implemented in the Monte Carlo code MCP6, which was used for those simulations. Then I used the model to calculate reference dose factors for different tissue regions for a total of 12 beta emitters and 6 decay genes of alpha emitters. So here in this video, you can see, for instance, the radiation tracks resulting from beta particles from iodine-131 emitted from the cortex. And what we can see is that even if the activity is just in the cortex, the energy is actually deposited also in surrounding regions. Now, this is how the phantom looks like in 3D and a cross section of it. So it is quite small, less than 10 millimeters in all directions, and it consists of a lattice of about, if I remember correctly, 2 million voxels of less than 80 microns. Now, each region corresponds to a tissue of kidneys. In particular, note the cortex rim in orange and the outer stripe of the outer medulla in yellow. So these are the regions that contain the glomeruli and the proximal tubules. Now, I cannot go over the specific results of the dose factors, but in general, I can say that what we found is that the activity distribution can have a substantial impact on the dose estimation of specific tissues. And this was particularly the case for alpha and low to medium energy beta and electron emitters. But I can anyway show you a case study where we demonstrated the applicability of the phantom. So we determined regional tissue doses for the non-uniform distribution of a single domain antibody labeled with iodine-131 based on the S values calculated with the phantom and the subkidney distribution of this radioligand, which we obtained with digital autoradiography combined with gamma count the whole kidney. And so here we can see the autoradiography images as a function of time. So the distribution of the radioligand is clearly very heterogeneous. There's a predominant uptake, early uptake in the outer stripe of the outer medulla, and to a less extent in the cortex. Then the whole kidney activity was allocated to different compartments of the phantom according to this autoradiography data. And then the tissue dose were estimated based on the iodine S value. And then as comparison, we also estimated the mean kidney dose rate, assuming a uniform distribution of activity in the whole kidney. And now here are some results. So here we see the dose rates for the different tissue regions for the two activity distributions as a function of time. And what we found is that the absorbed dose distribution is quite heterogeneous within the kidney. So the dose is particularly high for the outer stripe. It's about 2 times the dose of the cortex and the inner tissues. We also see that if we assume a uniform activity distribution, we would end up overestimating the dose to the cortex and the inner tissues, and largely underestimating the dose to the outer stripe. So the main message here is that it's important to consider the non-uniform distribution of the ligand in renal dosimetry. You can find more information about this study in this paper. Now, in another PhD project, we are looking into more detailed models of kidney tissues, more suitable for alpha particle and Auger electron dosimetry. So the PhD is done by Michelle Anderson and has the ambitious objective of developing a mathematical model for estimating kidney toxicity for terbium and lutetium dotatate. Now, the first step towards this goal is to develop a simulation framework that allows to model the differential dose distribution of these two radioligands. And the idea is that then, based on this framework and with detailed biodistribution experiments, we can provide the input to model dose response, the dose response of nephrotoxicity, based considering the dose distribution and also the specific radiosensitivity and architecture of the different kidney tissues. So now to start with the dose simulation framework, Michelle developed realistic models of nephrons of mouse kidneys based on three-dimensional microscopy data. So she identified 3 different types of nephrons, which vary in location, mass, and shape. So the low juxtamedullary nephrons, which are larger in size and have very convoluted tubules, and then intermediate and cortical nephrons, which are less convoluted and are also smaller in size. And as preliminary studies, she investigated the effect of nephron type on the dose received by the glomerulus and the proximal tubule for the same nephron, assuming a uniform distribution of lutetium or terbium in the proximal tubules. And without going into details, so what she found is that the absorbed dose to both the proximal tubule and the glomerulus are higher for terbium 161. And this is related to the higher yield of Auger electrons that emits terbium compared to lutetium. She also found that the size and the shape influence the dose estimations to both the proximal tubule and the glomerulus. So this might be something that needs to be considered in those estimations of Auger electrons and alpha emitters. Now, these analyses were done based on single nephron models only. Eventually, the idea is to make a more realistic multi-nephron tissue model, which can additionally account for the cross-irradiation between nephrons in order to improve the modeling of the absorbed dose distribution of these renuclides and other relevant renuclides as well. So I hope that with this presentation, it is clear that more realistic models of mouse kidney tissues are needed to improve the accuracy and therefore the relevance of those estimates used in preclinical radiopharmaceutical research. This will be important in the context of radiopharmaceutical development to improve the translatability of preclinical safety assessment of novel radioligands, and also to support the investigation of dose-response relationships of nephrotoxicity, including the influence of the dose distribution, the biological structure that are relevant for response, and then the further development of dose-response models which are needed to support treatment optimization. Thank you for your attention.
Thank you for the very nice presentation. Are there any questions?
Yes, if I may, I have a question for Clarita. Clarita, thank you very much. Very clear presentation. I would like to ask, so what, from your point of view, from the data you have and together with Michelle gathered from preclinical data, how far are we? And from possible personalized medicine on and use of dosimetric data on patients, so from the mouse to humans, with the tools that you have implemented, how applicable, how fast can we think about applying them and using them for the clinic?
Well, I think that that's a very good point. Of course, tissues of mice and tissues of humans are different for sure, sometimes in anatomy, but definitely in size. So it's important to use dedicated models for human dosimetry and for mouse dosimetry. As long as we do accurate dosimetry in both cases, then we can improve the gap in the translation of the dose effect relationships that we see in a preclinical setting compared with the clinical applications. However, there are challenges, and the challenges are both in the preclinical side as well as in the clinical one. So, of course, this kind of research that I'm presenting here addresses the issues from a preclinical perspective. Yes, so as I showed here, the absorbed distribution is a parameter that it's quite important in modulating the response of in healthy tissues. So in this case, in the kidneys. So I think that with this kind of models, if we do preclinical studies where we investigate more in detail the distribution of the radioligand, then we can better understand what we are seeing currently in the clinic, because this is really a clinical question. So this is not just like dosimetry for dosimetry in a preclinical setting, like pure basic research, let's say, but it's coming from a clinical need.
Thank you. No more questions from the audience. So maybe Victoria, we can kind of slowly conclude this webinar, if you agree. So as we thank you. So as we, ladies and gentlemen, as we are now coming to an end of this World Cancer Day webinar, I would like to thank Victoria. Thank you all for joining us today, and also a big thank you to our three dedicated speakers, Asta and Clarita and Koen, who made this particular event not only insightful, but also very inspiring. Let's remember the thematic of this year World Cancer Day. So the thematic is Close the Care Gap, and it's not just a call to action, but it's also a collective pledge to prioritize accessibility, innovation, and also compassion in the face of cancer. And this is precisely what we are trying to achieve within the PRISMAP community. So let's take all the lessons learned today and transform them into actions to bring us closer to a world where hopefully cancer is not just treatable, but also preventable. And so on behalf of the PRISMAP community, I would like to thank you all for your dedication to stand united against cancer. Have a lovely end of the day. Thank you very much.
Thank you. Bye-bye.